AML has really been like, over the last 10 years, we've more so even over the last 5 years, we've seen the approval of more targeted therapies. First with FLT3 inhibitors, midostaurin, and then more recently gilteritinib, and then now quizartinib. We've seen the approval of the IDH1 inhibitor, ivosidenib, and the IDH2 inhibitor, enasidenib, as well as now a third IDH inhibitor that's been approved. So there's really been significant progress being made in drug development. But that poses then the question, how do we sequence therapy? Because none of those therapies is actually curative. Maybe with the exception of FLT3 inhibitors in combination with chemotherapy in a frontline setting, then proceeding towards an allogeneic transplant. None of those FLT3 inhibitors or IDH inhibitors as a single agent is considered curative, and all patients eventually relapse. So then the question becomes really like, what is the optimal sequence of those therapies? And this is even more important now that we have really azacitidine plus venetoclax as the backbone of the treatment for older and intensive chemotherapy ineligible patients with AML. And when the trials of FLT3 inhibitors and IDH inhibitors were conducted, patients azacitidine plus venetoclax was not available at that point. And so we don't really have any prospective data that informs the response rates and the long-term outcomes of targeted therapies after patients had been previously treated with venetoclax. So that's a clinically relevant question where we don't have a clinical trial to answer and provide the information. So we conducted a multi-center retrospective analysis that was with patients enrolled at Yale, the Dana-Farber, City of Hope, and Memorial Sloan Kettering Cancer Center. So with this effort, we were able to come up with a nice cohort. I think it was around 50 patients, I think 53 if I'm not mistaken. And we then really looked at patients who had previously been treated with venetoclax and then progressed and were treated as the next line of therapy with targeted agents. And what we could show is that the overall response rate was around 20%, and the median overall survival was only around 4 months. So fairly limited efficacy, which is a little bit disappointing. But it also highlights, I think, that the clonal architecture over time gets more and more complex. Maybe it's just targeting one single clone with an IDH mutation may not be sufficient. And what's also interesting is that among 8 out of the 9 patients who responded in our series were treated with gilteritinib. And we know that emergence of FLT3 mutations is a resistance mechanism to venetoclax-based therapies. So I think in that context, it might be like, that was also an interesting finding, I think. But I think we're just still need to learn a little bit more about resistance mechanisms and clonal divergence. And maybe it's just insufficient to just target one specific clone with one targeted therapy. Maybe we need to think a little bit more broader.